Hi, I'm David Kerr, Professor of Cancer Medicine at University of Oxford. If one were to define me narrowly, I would argue too narrowly, I could be described as a colorectal cancerologist. I spent a career looking at the therapeutic options, studying the biology of colorectal cancer. Um, and what I'd like to talk a little about today is a nice article that popped up in Lancet Oncology by Per Pfeiffer and one of his colleagues from Copenhagen, in which he discussed the druggability of KRAS. Now, we know that colorectal cancer is the valley of death for many, many drug development programs. It's a tough nut to crack. And KRAS has been one of the most intriguing of targets for the past 20 years or so. It's been extraordinarily difficult to find drugs that are active against it. KRAS is one of the earliest oncogenes identified. I remember doing my PhD at the Beatson when I was a youngster with Alan Balmain, who was one of the early discoverers who worked with KRAS extensively. And here we are 30 years later, at last with some potential drugs that might work. We know that 30 to 40% of all colorectal cancers are KRAS mutant, but only 3% of those harbour a very specific mutation. It's codon 12 and it's a G to C mutation. So this is a very highly specific mutation. It's a minority of KRAS. But in 2013, there was a chemical breakthrough in that for the first time we had small molecular weight inhibitors that would bind fiercely and irreversibly to that specific KRAS mutant. Those drugs have proven to be effective in the treatment of non-small cell lung cancer, and they've got into an accelerated approval pathway as monotherapy. Two of the agents which have been mentioned are sotorasib and adagrasib, and they've done very well with non-small cell lung cancer. We know, we've talked about this before, we need to consider mutants contextually in terms of the tissue, the tumour type in which the microenvironment in which they come, and of course the different carcinogens at play in terms of the ontogeny and development of that tumour. No mutant is an island unto itself. Sometimes they are, but it's unusual. So back to KRAS, codon 12, G to C mutation. So these drugs have been tried as single agents and they've fallen short. Response rate's less than 10%. But some interesting new data generated initially by biology, showing that one of the resistance mechanisms to inhibition of this KRAS pathway, perhaps not surprisingly, is through EGFR signaling. Now, we know how to deal with that. We have cetuximab, we have panitumumab, and there are some recent basket trials which are being reported, which are coming through, showing that the addition of these specific KRAS mutant blockers with either panitumumab or cetuximab are giving us response rates in the order of 30 to 40%. This is very encouraging. Now, it's a tiny minority of colorectal cancer, but nevertheless, if we are to follow a personalised medicine approach, that leads us to have biomarkers that identify patients that will benefit, understanding the biology that allows us to put rational combinations together and to exploit these in the clinic. So a nice story, more data needed, larger patient numbers studied, but watch this space for an interestingly new addendum to the therapeutic compendium, the cupboard of drugs that we use to treat colorectal cancer, and a further step, small step, but a step nevertheless in the right direction towards personalised medicine of colorectal cancer. Thanks for watching and listening as always, but for the time being, Medscapers, over and out. Thank you.